Welcome to Mental Disabilities and the Criminal Justice System. I'm Elizabeth Kelley. I'm a criminal defense lawyer, and I specialize in representing people with mental disabilities. On this podcast, we provide information and hope to people with mental disabilities caught up in the criminal justice system, as well as to their families. This episode is part of a series where we will talk with various authors who wrote chapters in the upcoming second edition of my book, Representing People with Mental Disabilities, A Practical Guide for Criminal Defense Lawyers, published by the American Bar Association. In this episode, I will be talking with Dr. Carol Weiss. Dr. Weiss is a clinical associate professor of psychiatry and a clinical associate professor of psychiatry in medicine at Weill Cornell Medical College. Dr. Weiss wrote the chapter on substance use disorder in the second edition of my book, Representing People with Mental Disabilities, A Practical Guide for Criminal Defense Lawyers. Dr. Weiss, I noticed through the course of your chapter that you use the term substance use disorder as opposed to substance abuse disorder. Could you explain to us why you did that?
The diagnostic definition is called substance use disorder in the Diagnostics and Statistical Manual of the American Psychiatric Association. And abuse was felt to be a stigmatizing term, and there's a strong movement to reduce stigmatizing terms like addict and abuser, hence substance use. The person is using and has a disordered way of using.
That was helpful. And I also noticed that during the course of the chapter, you pointed out that substance use disorder is often co-occurring with different kinds of mental issues. Could you tell us what are some of those issues and if there's any reason behind that?
Well, that's a great question. There's a tremendous co-occurrence of substance use disorder and many other mental health disorders. At least 50% of people with substance use disorder also have a co-occurring mental health disorder. And conversely, at least 50% of people with mental health disorders also have a substance use disorder. So there are different ways of thinking about that. One notion is the self-medication hypothesis, and that is that people who have certain mental health disorders like anxiety or depression or trauma are medicating their symptoms with substance use disorder. Conversely, people who have a substance use disorder are at greater risk for developing a mental health disorder due to the nature of the use itself. You know, when you're in withdrawal from a substance, you experience anxiety and depression. When your body is continually in a state of either intoxication or withdrawal, that can precipitate or predispose one, I should say, to depression and anxiety. And then there's the theory that they both have a similar origin, if you will. Somebody who's vulnerable to one has the biology that would just predispose them. They travel in the same pathways in the brain. One particular co-occurring disorder that's worth mentioning is trauma. And that is that people who have experienced trauma have a much higher than 50% incidence of developing subsequent substance use disorder. And people with substance use disorders are just prone to being exposed to so much more violence and trauma, sexual violence, being in criminal situations or violent situations. Such a trauma that would lead to a post-traumatic stress disorder. So that's a huge co-occurring disorder.
You mentioned the criminal justice system, and that, of course, is the focus of the book. Can you tell us a bit about how substance use disorder might impact the accused's ability to make a decision, both in terms of the alleged act, what he or she is charged with, and also their ability to make decisions as the criminal case is pending?
Yeah, well, that's the $64 million question. Therein lies so much. Addiction, we've come to see, is a biological disorder. a very complex biological disorder, a brain disease, as they like to call it, or a disease that hijacks the brain. These are phrases that people have heard. And it is a disorder that is characterized by an impairment of volition, an impairment of choice, an impairment in decision making. But that isn't the same thing as involuntary behavior. There is some element of volition and accountability that's still present, but there is impairment. So this makes it very complicated to work with, knowing that the person has been compromised, but that their behavior is not involuntary. So it's important to understand this both as the person working with the individual as their advocate, as well as people who are passing judgment, that this person is compromised and you need to be aware of what that compromise is and how to best work with those deficits.
And the real challenge for us as criminal defense lawyers, as advocates for our clients, is making that argument to the court, particularly when the charges are serious, when there is serious destruction of property or perhaps an injury or even a death to another individual, which leads to the next issue. Are there some treatment modalities which are particularly effective?
Yes. By the way, what you said just reminded me of the concept that the addictive disorder or the substance use disorder is a mitigating factor. It's a variable. There is a biologic imperative to not go into withdrawal. Addiction is characterized by not only the seeking of the drug for the drug's effect, but there's also what's called negative reinforcement. And that is that the organism, the human being, is powerfully motivated to avoid withdrawal. Withdrawal not only can be profoundly physically uncomfortable, it can also be life-threatening. So the body is driven on a cellular level to maintain the use of the drug so as not to go into withdrawal. It's like, holding your breath. If you hold your breath for too long, you're going to suffocate. So that's what it's like to be in withdrawal. You have to get the drug to stay safe. So one of the most effective treatments available in the substance use disorder field is what are called, basically replacements. That's called agonist therapy, safe medications that keep the person from going into withdrawal by maintaining a safe level of the drug in the system, keeps the person from being driven to have to use, and whatever is involved in having to use, selling, dealing, prostituting oneself. So that is sort of the basic level of a very important treatment to provide. Now, unfortunately, not all drugs have replacement medications. It's something that can be helpful for alcohol and for opioids, but that isn't available for example, stimulants, amphetamines, cocaine, methamphetamine, like that. But one of the fundamental principles is to make sure that the person, if they are using a drug that can be replaced, that they have it replaced with a safe medical alternative.
That is hugely, hugely significant and important. And my sense is that there are many criminal defense lawyers. There indeed may be many patients as well as their families out there who don't even know about this.
Well, who don't know about it, or if they do, there is a stigma associated with that, with being on it. There's a barrier to going on it, not just among professionals, but among the patients and the addicts themselves, because they want to be drug-free. That's a big goal for many of them. Or there's a stigma associated with being on these medications. So, so there's that too to bear in mind. Sorry to interrupt.
Oh, no, not at all. And I would imagine that it also goes back to the perception in the eyes of some judges and some prosecutors that substance use disorder is fundamentally a moral failing.
Yeah, well, that is a very old notion for centuries that my field has been working very hard to get rid of, that it isn't a moral failing or a weakness or a character flaw or a lack of spirituality or any of that. They're biological determinants. There are genetic components. It runs in families, even if the people have been adopted away. It does alter one's body chemistry. And there is a biological drive. Imperative is the word I would use more than drive for the use. And it takes, tremendous help to overcome this. And again, I'd like to repeat, it's true that there are judges and people in society that have that stigma, but so much so even the patients themselves feel that they are weak and they are ashamed and they feel that they should have these strengths, they'd like to say, to do it on their own. And if they need help, it means that they are weak. So you're really battling this from both sides.
Yeah. And once these individuals get ensnared with the criminal justice system, sad to say, they've hit bottom. I would assume that when you use the term substance use and drugs, you also mean alcohol, correct?
Yes, absolutely. And nicotine. Nicotine is also addictive, but there is less crime associated with nicotine as there is with alcohol and other drugs of abuse.
Understood. Now, let's go back to the criminal justice process. If a criminal defense lawyer retains an expert, probably an expert in addiction, what are some of the key questions that attorney should ask the expert to highlight the effects of a substance use disorder on a defendant's behavior?
First, the expert needs to determine whether or not the person has a substance use disorder, whether or not they meet criteria for that disorder. Then the substance abuse expert.
Let me back up. Let's say that someone is charged with a crime and they were drinking alcohol before that. It could be something as simple as a first time driving under the influence, or it could be something as complicated and as tragic as aggravated vehicular homicide. How does the attorney know? What are some of the questions that attorney should even ask themselves in advance of retaining an expert?
The attorney needs to determine whether or not they are going to pursue a route that this is a mitigating variable, that the fact that the person was intoxicated is something that they want to present as a mitigating factor. Otherwise, I don't know how else they would be bringing it in as part of the defense.
Let's say, for instance, that the client is, and I'm dwelling on stereotypes, an 18-year-old male and it's his first DUI. Is the attorney, for want of a better phrase, overreacting to bring in an expert, or should that attorney just chalk it up to basically a kid being a kid?
Oh, okay. No, no to the latter. In terms of if someone commits a crime or causes harm to themselves or others while under the influence, they've already met one or more of an important criteria for substance use disorder. We also often assume in my field anyway, that if the person is caught with a DUI, then we can assume that there have been other instances of driving while intoxicated where the person wasn't caught. So yeah, it's extremely serious. I don't even mean that from a legal perspective, but I mean from a diagnostic perspective and a mental health perspective. When someone has a DUI, it means that they did something against their better judgment, which is also at the core of the diagnostic definition of the disorder, doing something that is not healthy or correct, but you were compelled to do it, or your judgment was impaired such that you did something wrong.
All right. And when a criminal defense lawyer has such a client, are there some particular qualities that an attorney should look for when retaining an expert?
First of all, the expert needs to have expertise in substance use disorders. General psychiatry is attempting to train there, and psychology as well, for that matter, to learn more about addictive disorders, and they're doing better and better. But you still do need someone with expertise in this area, someone who has also worked in the forensic sphere before and is comfortable with, understanding impairment, voluntary versus involuntary judgment, mitigating factors, et cetera. So that's something that you should look for, someone who understands about treatment, though that is intrinsic in someone who has expertise in substance use disorders.
You mentioned voluntary versus involuntary. And that is often a difficult concept in the legal profession because you can make the argument, well, no one put that drink in his hand. No one forced him to drink. No one put that needle in her hand. No one forced her to shoot up. How do you respond to that?
Precisely, that is the crux of the matter. This is true, but the person is driven by forces larger than themselves. Their own illness forces them to need to not go into withdrawal, to prevent a seizure, or to prevent profound discomfort. Again, it's a biologic imperative. So one needs to understand how the illness drives people to engage in behaviors. Now, again, that doesn't mean that they don't have any responsibility, but they do have diminished responsibility, if you will. So, yeah, it's about understanding that the person needs to be treated for the illness, not just punished for the behavior. They're both relevant.
I like that phrase that they are driven by forces larger than themselves. And I can see a very cynical prosecutor, a very cynical judge saying that I came from a family of alcoholics, but I'm not an alcoholic. Or I came from a family where people abused fill in the blank, marijuana, cocaine, opioids, and I don't abuse those substances. How do you respond that one person is vulnerable to forces larger than themselves, but another person may not be?
Well, there's so many variables that determine whether or not someone will develop this disorder. There's psychological variables, genetic variables, socioeconomic variables. And it's true, not everybody with the exact same circumstances will end up in the same place. That's the case for, diabetes as well. Everybody has their own composite of risks and vulnerabilities. One person may have had more anxiety than the other, and the anxiety was overwhelming, and they leaned more towards self-medication. The other person didn't have as much anxiety, though they were in a home where there was as much alcohol, for example. In many ways, it's about luck, if you will, the luck of the draw. And many people do say there, but for the grace of God go I. There are traits as to why one person in a terribly disadvantaged family ends up, going to college and law school and becoming a lawyer, and everybody else ended up in prison. It's not necessarily moral strength. It's many, many variables, many of which are out of their control. That's not to say, again, that people don't have the strong traits that enable them to succeed in either recovery or, getting out of a bad, disadvantaged circumstance, but it's not a moral issue.
Final question for you, Dr. Weiss. If someone abuses substance over a span of years or even decades, is there a danger for long-term brain damage?
Yes, it depends on the substance and it depends on how long. And also, brain damage is a very broad term, but certainly chronic alcohol use can lead to loss of brain matter and loss of balance and loss of memory and a lot of other cognitive and neurologic functions that do not come back. Many of them can be improved with abstinence or sobriety, but sometimes the damage can only be reversed or turned back to a different degree, a small degree. There are definitely brain changes associated with, say, for example, cocaine use and opioid use. And many of those brain changes do revert over time, but sometimes we're talking about a matter of years. And one of the things that often doesn't revert, however, is the vulnerability to still having an addictive disorder. Even years after you haven't used, that sensitivity of that part of the brain that is key to substance use disorders remains sensitive, if you will. But for many substances, you can gain back a lot of function, but one needs to be patient because it can take years.
Interesting. I did not know that. Well, Dr. Weiss, Thank you again for a wonderful chapter, and thank you for joining me today in what I hope was an educational and a compelling conversation for our audience.
My pleasure. Thank you very much.